2025, a collaborative CME initiative that brings together experts across disciplines. This unique platform aims to bridge the critical intersection between rheumatology and obstetrics, where the stakes are not only high but extremely complex and evolving. Today's session is especially important as we turn our focus to the management of pregnancy in patients with autoimmune diseases, particularly SLE, known as systemic lupus erythematosus, and antiphospholipid syndrome. These conditions demand not only medical expertise, but coordinated, compassionate care between specialists. In line with that spirit, our discussion today will revolve around two key themes: pregnancy in autoimmune disorders, risk assessment and multidisciplinary care, presented by our rheumatologist, Dr. Srikriti Shrestha. And another topic for today is immunosuppressants and biologics in pregnancy, what's safe and what's not, presented by rheumatologist, Dr. Sudhir Karmacharya. We also have a compelling panel discussion based on a real-world case that encapsulates the clinical challenges and decision-making dilemmas encountered in managing pregnancy in a patient with lupus nephritis and suspected APS. We hope today's CME fosters collaboration, inspires new perspectives, and ultimately enhances the care we provide to women navigating pregnancy with autoimmune diseases. Thank you once again for joining us. Let's begin the session. Today's first talk will be presented by Dr. Srikriti Shrestha, and this session will be chaired by Dr. Deena Shrestha, consultant endocrinologist working at Morvik Hospital. Please, Dr. Deena, please chair the session. Please be seated. And I would like to welcome Dr. Nikita Dhakal, consultant gynecologist and obstetrician and IVF specialist at Salvika IVF Center. Please kindly be seated. I would like to welcome the first speaker.
So we can do that, I guess.
Thank you.
Hello everybody, and I feel privileged to be chairing this really nice session. I have to say, I said only yes because I wanted to learn, and like rheumatic disease and pregnancy, that sounds fun, right? Something not we're going to sleep, is going to keep us awake till dinner time and maybe the whole night. So Dr. Srikriti Shrestha, MD rheumatologist, a consultant rheumatologist at the National Center of Rheumatic Disease, and she's going to talk about this vast subject, pregnancy and rheumatic disease. So let's give her a warm welcome.
Good evening, everyone. Today we are going to delve into a critical yet common area of medical practice, pregnancy in rheumatic disease. This is a topic that needs our collaborative approach as rheumatologist, gynecologist, obstetrician to ensure best possible outcome in both mother and her fetus. I am going to analyze the key aspects of risk assessment and highlighting the crucial role of multidisciplinary care. The landscape of rheumatic diseases is diverse, encompassing different conditions like systemic lupus erythematosus, rheumatoid arthritis, antiphospholipid syndrome, systemic sclerosis, Sjogren's syndrome, and so on. In Nepal, around 15 to 17% of population are living with some kind of rheumatic diseases with obvious female predominance. Pregnancy in women with rheumatic disease poses unique challenges. Yes, with advancement in medicine, there are numerous successful pregnancy outcome, but these patients are always at higher risk for adverse maternal and fetal outcome compared to the general obstetric population. Rheumatic disease has great impact on pregnancy, affecting both maternal and fetal outcome. The effect depends on which rheumatic disease we are dealing with, its disease activity and presence of certain autoantibodies. But here are the general effects of rheumatic diseases on pregnancy. Maternal risk includes flare. Pregnancy itself is a period of altered immune state. Disease may go into flare in some conditions like SLE, where there is immune reconstitution, whereas in some conditions such as rheumatoid arthritis, disease goes into remission during pregnancy and flare in postpartum period. Risk of preeclampsia, eclampsia, thromboembolic events is higher in patients with SLE and APS. With the use of high-dose steroid and for long-term use, it increases the risk of gestational diabetes. With the use of immunosuppression, there is increased risk of infection. There is higher rate of cesarean section due to complication or due to maternal complications. There is always medication challenge because most of the medication that we use are teratogenic. So we have to switch to the pregnancy-friendly medicine. Fatigue and musculoskeletal pain escalates due to physiological demand of the pregnancy. As for fetal risk, miscarriage and recurrent pregnancy loss is mostly seen in APS and SLE patients. Stillbirth, preterm birth are associated with high maternal disease activity. Preterm birth can also be due to early delivery that is planned for fetal and maternal well-being. Fetal growth restriction is due to because there is effect in placenta due to inflammation and clot. There is risk of neonatal lupus and congenital heart block in patients patient with presence of antibodies anti-Rho and LA. And due to all this, there is obviously increased risk of neonatal intensive care unit use. As described earlier, there is also an effect of pregnancy on rheumatic diseases. Some disease goes into remission while some flares during pregnancy. Okay, so after knowing the general effect of rheumatic diseases on pregnancy, now is the time to assess the risk of each disease. It is a multifaceted approach which requires various factors. We should always assess the disease activity of the patient. It can be low risk or high risk. Low risk if the disease is in remission or low disease activity for at least 6 months prior to the conception. High risk if there is recent flare or disease is active in 6 months prior to the conception period. We should always go for disease optimization. That means we should target for keeping the disease in remission or at least in low disease activity for 6 months prior to the conception. The risks depends, of course, with the specific disease. We'll go into detail of each disease in upcoming slides. If there is no organ involvement, the risk is obviously low. But if there is organ involvement, there is risk of there is high risk and there is chance of worsening of that organ involvement. For autoantibody profile, if there is presence of anti-Rho, anti-La, there is always a high risk of neonatal lupus and congenital lupus in child. Whereas with the presence of antiphospholipid antibodies, there is chance of recurrent miscarriage, of stillbirth, low birth weight, and intrauterine growth restriction. If there is high anti-DS DNA with low complement level, there is chance of adverse pregnancy outcome. If there is history of spontaneous abortion, stillbirth, recurrent fetal loss, and history of preeclampsia, eclampsia. These are the risk factors for, strong risk factors for future pregnancy as well. As I told earlier, medication regimen, low risk is if the patient is in remission with well-established pregnancy-safe medication that are hydroxychloroquine, azathioprine, low-dose prednisolone, some biologics. And high risk if the patient is requiring medicine which have limited pregnancy safety. Other risk factors for the risk assessment includes polyautoimmunity. It is not necessary that one patient will have only one autoimmune disease. They can have multiple autoimmune disease, and it is one of the risk factors. Whereas the presence of comorbidities like obesity, hypertension, pre-existing diabetes, kidney disease from any other causes, cardiovascular disease, and age of the mother more than 40 is additional risk factors. With that, if there is lack of access to the care and compliance with the treatment, it just adds up to the risks of the mother and fetus. Now let's go one by one according to the diseases. The most important one being the systemic lupus erythematosus. Systemic lupus erythematosus is one of the most studied autoimmune diseases in pregnancy due to its potential for significant complication. The risk increases by 2 to 4-fold in SLE compared to the normal obstetric population. The risk associated for maternal are flares. It can flare mostly in second, third trimester as well as in postpartum period. The risk of preeclampsia, eclampsia, and thrombotic events increases up to 23% in presence of concurrent APS. With the use of immunosuppression, there is high risk of infections. Whenever there is flare during pregnancy, in around 75% of cases, it is lupus nephritis. Miscarriage and stillbirth are common in SLE. 20% of fetal loss is seen during due to fetal loss due to SLE. Congenital heart block, as told earlier, is common if mother is positive for anti-Rho or anti-La antibodies. Well, this is the bar diagram showing risk among SLE patient and non-SLE patient, where all the risks are increased in SLE patients compared to normal obstetric population. While assessing the risk for SLE, high risk factors include if the lupus activity is higher during conception, before the period of conception, and if there is flare of lupus nephritis, it is one of the predominant factors that have adverse effect on both maternal and fetal outcome. Presence of antibodies like antiphospholipid antibodies and anti-Rho-La is more connected with adverse effect in fetal, whereas low risk is if disease is in remission for at least 6 months on no drugs or at least minimal or pregnancy safe medications. SLE flare and preeclampsia is often a topic that is misdiagnosed, or there is confusion between is it SLE flare or is it preeclampsia. So here is the differentiating point between SLE flare and preeclampsia. SLE flare can occur in any stage, whereas preeclampsia normally occurs after 20 weeks of gestation. Blood pressure may be elevated in both cases, but in preeclampsia it is defining features. Same goes with proteinuria. But in SLE flare, complement level will be low, anti-DSTNA level will be elevated, urine sediment will shows active cast in SLE flare, but it is usually blunt in preeclampsia. In case of preeclampsia, there may be elevated of uric acid, whereas in SLE flare, uric acid level will be normal to low. SLE flare, there will be other organ involvement because it is a multi-system disease. And the treatment varies, the treatment pattern differently varies. In SLE flare, we go for increase in steroid dose with immunosuppression, whereas in preeclampsia, the definite treatment is delivery if there is viable fetus. Next is antiphospholipid syndrome. This is one of the autoimmune disease where there is adverse pregnancy, morbid outcome, and vascular thrombosis with positive antiphospholipid antibody syndrome. It can be primary or secondary. Generally, around 30% of APS is associated with SLE. It is one of the major acquired cause of adverse pregnancy outcome. Talking about maternal risk, there is chance of severe preeclampsia and eclampsia. The risk increased by 20 to 50% than in normal general population, and preeclampsia, eclampsia occurs early in the mother associated with antiphospholipid syndrome. Same goes with HELP syndrome. It occurs early, it can occur before 20 weeks of pregnancy. Recurrent miscarriage and stillbirth, fetal growth restriction, preterm birth are associated fetal risk with antiphospholipid syndrome. Okay, while assessing the risk for APS, what are the high risk factors associated with APS? If all three antibodies are positive in high titers, if there is history of arterial thrombosis, history of recurrent pregnancy loss despite adequate treatment, these are all the high risk factors associated with APS. But if there is only single positive antiphospholipid antibody or low titer, a successful prior pregnancy, these are the low risk factors. Now next is rheumatoid arthritis. It is a chronic inflammatory disorder that can affect any tissue. Most women goes into remission during pregnancy. Around 75% of women are in remission, among which 50% are mostly in first trimester. But it flares up postpartum. Around 60 to 70% of patient needs medical escalation after in postpartum period, which generally flares in 3 to 12 months of postpartum period. There is no definite fetal risk, but there is slightly increased risk of preterm birth, low birth weight if the disease is active. If the disease is active during conception, it is considered as high risk for rheumatoid arthritis. And if disease is in well control, in remission, on pregnancy compatible drugs, it is the low risk factor for rheumatoid arthritis. Next is Sjogren's syndrome. It is chronic autoimmune inflammatory disease affecting glandular and extraglandular structure. It can be both primary and secondary. The risk of flares in Sjogren's syndrome is generally low in comparison to SLE. Important one is fetal risk. There can be risk of neonatal lupus and congenital heart block if mother is positive for anti-Rho and anti-La antibodies. So as said earlier, the high risk includes the presence of antibody and presence of active systemic features. Congenital heart block is one of the most serious and potentially life-threatening complication. It should be seriously monitored. It occurs when the maternal autoantibodies cross the placenta and damage the fetal cardiac conduction system. It can be first degree, which is generally mild or asymptomatic, second degree where there will be intermittent block, and third degree, that is the most dangerous one, which requires permanent pacemaker. It usually occurs between the 18 to 24 weeks of gestation, and the mortality associated with this is around 20 to 30%. So how are you going to monitor it? Any patient with antibody Rho La positive, for them preconception counseling is very important. It is not necessary that the fetal will develop congenital heart block, but she should know the risk associated with that condition. So the mother should be well counseled. And for fetal surveillance, what will we do? We will do serial fetal echocardiogram, which we will start from 16 weeks of gestation and continued until 28 to 30 weeks of gestation. Home Doppler monitoring is not usual practice in Nepal. For the management, hydroxychloroquine, it reduces the risk of congenital heart block. So any patient, any mother with Rola antibody positive, hydroxychloroquine should be continued throughout the pregnancy. We had one case where we discontinued hydroxychloroquine due to hyperpigmentation of her skin, and in that very patient, that fetus developed congenital heart block. We can use corticosteroid if first or second degree congenital heart block is detected. Dexamethasone can be used, but it is not used as prophylaxis treatment. Next is systemic sclerosis. It is autoimmune connective tissue disease characterized by fibrosis of skin and internal organs. The most important risk factors associated with it is Scleroderma renal crisis. Why? Because for the treatment of Scleroderma renal crisis, we need to have AC inhibitor, and AC inhibitor is contraindicated in pregnancy. So we should always keep that in mind. Another risks are pulmonary hypertension and increased risk of preeclampsia. Fetal risk associated with systemic sclerosis are preterm birth and fetal growth restriction. As I have described earlier, for the risk assessment associated with systemic sclerosis, pulmonary arterial hypertension, active scleroderma renal crisis, severe restrictive lung disease, these all are the absolute contraindication for pregnancy. So we should keep that in mind and counsel the patient accordingly. There is low risk if there are limited cutaneous systemic sclerosis with no significant organ involvement and the disease is stable for a few years. Okay, spondylitis is chronic systemic inflammatory disease affecting the axial skeleton, incisives, and peripheral joints as well. There is no direct fetal risk, but in some, it can flare, especially in second trimester and postpartum period. Okay, once we have gone through the risk assessment individually according to the disease, now what? Now, for optimization of the outcome in this patient, we have to have collaborative approach where there is collaboration between multiple disciplines. The core team includes rheumatologist, gynecologist, obstetrician. So what is the role of rheumatologist? Rheumatologist will assess disease activity, organ damage, medication review, change the medication to pregnancy-friendly one, describe the risk to mother, her family according to the specific diseases, and what is the role of gynecologist or obstetrician. They will assess the antenatal, interpartum, postpartum surveillance. They will mostly look for the fetal risk, fetal growth, amniotic fluid, volume, any adverse effect related to fetus, risk of preeclampsia, eclampsia, they will monitor. Essential collaborators are neonatologist, nephrologist, cardiologist, and anesthesiologist. They will be collaborated according to the organ involvement. Okay, so once the core team is produced, so what is the next step? The key component of multidisciplinary care is preconception counseling. As the name suggests, preconception counseling, it starts before conception. So what are we going to do during preconception counseling? We'll discuss the risk associated with the disease. The mother should know what will be the effect of rheumatic disease on her pregnancy or effect of pregnancy on her rheumatic disease. We should focus on the I think that the disease should be well controlled. It should be in remission or at least have low disease activity for at least 6 months prior to the conception. It will lower the risk of any adverse effect. We will adjust the medication because not all patients are on pregnancy friendly medication, so we'll have to adjust the medication to pregnancy friendly one, and then we will establish a care plan which will be individualized because each pregnancy is different. Then there should be seamless communication and coordination between caregivers and the patient so that we can know what gynecologist is planning or what rheumatologist is planning so that we can counsel or we can follow the step accordingly. Antenatal care includes regular monitoring. Maternal monitoring includes clinical assessment of flares. We should see the sign of symptoms in each visit. There should be BP monitoring for the risk of preeclampsia, eclampsia, and lab investigation according to presentation, according whatever is needed at that time. Sometimes antibody should also be regularly monitored. For fetal monitoring, we have to do serial ultrasound for surveillance of fetal growth, amniotic fluid volume, and fetal echocardiography for anti-ROLA positive mother, as I told earlier, from 16 weeks to 28 to 36 weeks. Okay, interpartum planning is for delivery planning. We will plan on the timing and mode of delivery, considering the maternal disease activity, fetal well-being, so that the outcome will be positive. With that, we will have anesthesia consideration as well as steroid consideration. If mother is on long-term steroid, we need to have stress dose before delivery. In postpartum care, it is important because most of the disease flare in the postpartum period. So we need to monitor for disease flare. There should be careful management of immunosuppression because after delivery there is breastfeeding period where there is restriction of certain medication because it can affect the baby. We should counsel for adequate contraception. Hormonal therapy should be used with caution in patient with APS or with history of clot. Post-pregnancy is emotionally challenging for a mother, especially if she is dealing with a chronic illness. So postpartum depression should always be addressed and there should always be psychological support for the mother. Okay, this we will do as a collaborative approach, but for successful outcome. But there are certain conditions in which we should not allow the patient to go forward with pregnancy because it is harmful for the mother. So we should actually explain the absolute risk associated with those conditions. There are absolute and relative contraindications for pregnancy. The absolute indication includes severe pulmonary arterial hypertension. Absolute is if more than 50 mm of mercury. Severe restrictive lung disease if forced vital capacity is less than 1. Severe active lupus nephritis with significant renal impairment. Yes, there is data of successful pregnancy in lupus nephritis patient if it is well controlled, but in severe active lupus nephritis there is high chance of end organ damage. So in severe cases it should be restricted. Similar case goes with severe cardiac disease if there is severe uncontrolled heart failure and severe valvular heart disease. And next one is active or severe scleroderma renal crisis. I have explained that earlier. Relative contraindication includes active autoimmune disease at conception. I've already mentioned why is it necessary to have the disease in remission or at least in low disease activity for positive both fetal and maternal outcome. if there is moderate renal impairment, and if there is history of severe preeclampsia or HELLP syndrome in previous pregnancy, it is one of the relative contraindication. If there is presence of anti-Rho-La antibodies, it is not definite contraindication, but the risk should always be explained to the patient. And if there are prior thrombotic events, repeated thrombotic events, then also mother should know about the associated risk, so she can plan accordingly. So the take-home message is pregnancy in women with rheumatic diseases can have an increased risk of adverse maternal and fetal outcome. So for that, preconception counseling is very much important in those cases. Preconception counseling includes not only keeping the disease in remission for at least 6 months, but it should include all the risk factors associated with pregnancy for mother as well as fetus, so she can decide at the end. These high-risk patients should always be managed as interdisciplinary team, not as individual doctors, not as rheumatologists, not as gynecologists or obstetrician, but we should always form a team so that we can have successful pregnancy outcome. Thank you.
Thank you so much, Dr. Sukriti. That was wonderful. I think she covered up everything, and I'm sure everyone understood. I'm like the revision just about the gynec. So basically, I don't practice much of obstetrics, but I remember one time we had this patient, Dr. Beneath and me, we were doing this SLE Lupus patient, and she had a history of infertility. And pregnancy we didn't have to do any treatment, so she came to me. Everything was remission, everything was controlled, and everything was going very smoothly. So parameters were also, everything was fine. But 34 weeks, she preeclampsia, she blood pressure shoot up. Discussion with Dr. Beneath and everything, we decided to do immediate delivery management. And thankfully, because Saturday, I still remember this case very well because it was Saturday, we had told her that signs and symptoms blood pressure being the most common one. We told her that headache clinic pharmacy BP monitoring. So her BP was when she came to the hospital around 170, 110. We delivered the baby, we got a healthy corticosteroid average, so we delivered the baby, 2.2 kg healthy male baby boy, 2 days I think NICU ma rakyo. Patient after the delivery she got fine and we were lucky. Our outcome not but yeah, we did. That was one patient I remember. So I don't get much as lupus patients, but I remember her very well. Thank you so much. Okay, guys, you have any more questions? Dr. Akriti?
One question. Hi, I'm Dr. Akriti from Vatsalya. For the speaker, do we have to continue at sequel post-delivery also, or do we stop right after delivery?
In normal patient or SLE patient?
SLE or ANA positive or Rho-La positive.
We will continue hydroxychloroquine throughout pregnancy also?
Yeah, throughout pregnancy we do, but after
delivery also we will continue.
Till when?
Indefinite.
Oh, okay.
Because they are SLE patient.
Mm-hmm.
It can flare up anytime. Hydroxychloroquine will, if she is maintained only on hydroxychloroquine, then we will continue it throughout lifetime.
Okay. And do you routinely recommend to do the corneal evaluation before starting hydroxychloroquine?
Generally, we do at baseline and then after 5 years.
Okay. So before starting, it's routinely recommended.
Yeah.
Thank you.
Regarding hydroxychloroquine, the one important thing about hydroxychloroquine is it is only drug that is shown to reduce the level of antiphospholipid antibodies. So especially not only in cases of lupus, if it's only lupus, only primary APS or lupus with APS, hydroxychloroquine is mandatory because it's the only drug that is shown to reduce the level of APS antibodies in these patients, in addition to anticoagulation. Second is hydroxychloroquine is mandatory in stop-ins, especially if lupus patient has SSA antibodies or the patient is primary stop-ins, it is mandatory. We had only one case because of the skin pigmentation. She had the cosmetic problem and we stopped hydroxychloroquine. She was pregnant and the kid developed first degree heart block. Luckily, it was only first degree heart block. Admitted the patient, started on dexamethasone, and finally, yes, the heart block resolved. The outcome was good, but she had to get admitted for a long time. So, and from now on, we never stop even for cosmetic reasons. So these are two indications we do not stop hydroxychloroquine. And postpartum, yes, if there are any contraindications like cosmetic problem or skin itching, or if there's retinal toxicity, you can switch to azathioprine, which is again a safe drug in pregnancy. But then if there's no other side effects or contraindication, we do continue it indefinitely. Yes, in antiphospholipid syndrome, yes, we tend to continue anticoagulation 6 weeks postpartum. And hydroxychloroquine, we continue until and unless there's any other contraindication like skin allergy or retinal toxicity. We continue it because that's the only drug that reduces the APS antibody levels. There are no other drugs, even steroid, they do not reduce the levels. So we continue.
And what do you recommend? Would you like to prime that patient with NCQ prior and then start up with pregnancy, or directly within pregnancy we can start? Or like in case of refractory APLA only, we start with NCQ, and in other cases where the treatment wasn't initiated, in such cases we do only continue with ecosprin and low molecular weight.
Regarding APLA, if the patient doesn't have any previous history of miscarriages, we usually would not have diagnosed it until and unless the patient is already known case of lupus, then we screen for APLA. Otherwise, if the patient is asymptomatic, no prior history of miscarriages, we do not know if the patient has that thing. So if the patient is a diagnosed case of antiphospholipid syndrome and is planning pregnancy, at least 3 months before we start with aspirin and hydroxychloroquine, and once the patient conceives, as soon as the UPD is positive, we start with low molecular weight.
Thank you.
No, hydroxychloroquine, the loading dose is usually 400 milligram or 200 milligram twice a day, because we have observed a little less skin pigmentation with twice a day dose than 400 once a day. It's for 3 months, and after the loading dose, we maintain with 200 or 300 milligram maximum of hydroxychloroquine indefinitely. We do not continue 400 for a long time because retinal toxicity is the risk is doubled and skin pigmentation is doubled. Basically, hydroxychloroquine is the safest drug that is available in these cases, and safe in pregnancy, safe in lactation, no immunosuppressant. It's just an immunomodulator, it's not immunosuppression. So there's no monitoring required, at least for the initial 5 years. After 5 years, if the patient is still on hydroxychloroquine, then we do send for retinal screening, and after 5 years, it has to be done yearly. And what we have observed is those patients who have skin pigmentation are likely to have retinal pigmentation. Those who do not have skin changes, less likely they have retinal changes. And those that hydroxychloroquine induced retinal changes tends to be permanent. So after 5 years, we screen them yearly. But then most of the cases, hydroxychloroquine, which is started early in the phase, except in cases of lupus, they are usually on some other immunosuppression due to renal or pulmonary involvement. So if they are already on azathioprine or mycophenolate, we can stop hydroxychloroquine because they are already active. But if the patient is on monotherapy with hydroxychloroquine with no other immunosuppression, then it is mandatory.
So you said you start hydroxychloroquine 3 months. For 3 months we need weekly. So is it recommended or?
Yes, starting dose is usually 400 milligrams. So
Because in my practice, what I was doing is I was using 200 milligram BD for initial 2 months, and then I tapered to OD dose. So is it like for 3 months?
Usually loading dose is recommended 3 months, but yes, because it is a very long acting drug, you can give for 2 months and then you can reduce the dose.
Thank you.
that was a really good discussion, and Dr. Vinit took over the baton very well. So, Sweetie, can I ask you something? For a leaving message, what do you think? Like, what are the red flags we have to look at? Like, so it seems that you get into complications a lot with these pregnancies, right? So, what is your take-home message for all of us that being rheumatic naive, what are the things that really we should be worried about? And when should we say, okay, this is it. Okay, like, take care.
Overall rheumatic patient or SLE patient?
You're talking about rheumatic.
Overall, we have to look for the flares, if there are flares or not. In specific SLE patient, like I said, we have to differentiate between is it really flare or is it preeclampsia or eclampsia. That should be always ruled out. And plus, it should always be differentiated from it should always be differentiated from physiological changes of pregnancy, because there are certain changes that you will see in pregnancy. So there should always be differentiation between if there is physiological changes or normal physiological changes, or there is flare of the rheumatic disease. So you have to differentiate that.
I don't have a mic, but thank you. We will conclude that, and thank you so much. If there's no other burning question, we will conclude, and because of the next talk. So thank you so much.
Thank you very much. Wonderful talk, and thank you, Chairperson. And now, next session, I would like to Now, next talk is about the pregnancy, about the immunosuppressant and biologics in pregnancy, what's safe and what's not. That will be presented by Dr. Sudhir Karmacharya. Before that, I would like to invite the chairperson for this session, Dr. Beena Basnet, Senior Consultant and Obstetrician. Kindly, ma'am, please take over the seat and invite the speaker.
Good evening, everyone, and welcome to today's CME. My talk is on immunosuppressant and biologics in pregnancy, what's safe and what's not. So before digging deep into the topic, today's learning objective will be understanding the general principles of immunosuppressant and biologics during the pregnancy and conception, review the safety data of commonly used immunosuppressant and biologics, and how to recognize the specific risks like teratogenicity, miscarriage, neonatal effects. So this picture basically describes the different stages of fetal development and how exposure to different drugs can affect the baby, and when is the most vulnerable time for the exposure of teratogens and causing teratogenic effect. So the first 2 weeks is a period of implantation where the risk of developing any teratogenic effect is very low. The week 3 to week 9 is most vulnerable period where organogenesis occurs, and exposure to any teratogenic medicine can cause teratogenic effect in this period. And after 9 weeks, it is a period of fetal development. Though teratogenic effect is very low here, but there may be some developmental risks or growth risks. So, what are the general principles of prescribing the immunomodulatory and biologics during the pregnancy? Preconceptional counseling is very essential. Counseling regarding the discussing regarding the time of conception, disease control, drug safety and contraceptions. Avoiding the pregnancy incompatible medicine and converting them to the pregnancy compatible medicine. But when there is no alternatives available, then we have to prioritize the maternal health. Discuss the risks and benefit of the treatment to both mother and fetus with all the healthcare provider, including gynecologists and treating physicians. Biological DMARD, some of the biological DMARD can be continued throughout the pregnancies whenever it is needed. Infant vaccination should be individualized depending upon the in utero drug exposures. Use of the lowest effective dose to the shortest period of time of immunosuppressants is recommended by most of the guidelines. There are limited data regarding the paternal exposure of immunosuppression and biologics, but it may affect the fertility, but there is no proven harms to the fetus. Therefore, we usually follow the guidelines similar to that of maternal exposures. So for the practical purpose, I have divided the medicines into 4 categories that are risks, that causes the risks during the pregnancy. The drug with the minimal fetal and maternal risks that can be continued throughout the pregnancy. Selective use allowed during the pregnancies. Third one is moderate to high risk fetal harm that is contraindicated during the pregnancy and with the limited studies unknown risks. So what are the medicines, what are the drugs that we commonly use in rheumatological condition during the pregnancy that are safe throughout the pregnancy? These are hydroxychloroquine, sulfasalazine, low dose aspirin, azathioprine and colchicine. So let's go with the individual drugs. Hydroxychloroquine is very safe throughout the pregnancy. The benefit always outweighs the risks, and in many studies it has shown that there is the good outcome, especially in the pregnancies, both in the maternal and fetal. But there are certain small studies where there are shown the risks of congenital malformation seen in the certain study with relative risks of 1.2. So it is also safe during the lactation, although there is slight transmit through the slightly excreted through the breast milk. So in this study, 273 patients were categorized, pregnant women who were pregnancy were categorized into 3 groups, one with the hydroxychloroquine, another group without hydroxychloroquine exposure, and third one was exposed with hydroxychloroquine, but they were terminated in 3 months. So in all the 3 groups, the risks of miscarriage, stillbirth, pregnancy and congenital abnormalities were not statistically significant. Therefore, hydroxychloroquine can be used throughout the pregnancy. The another drug, sulfasalazine, it is also very safe during the pregnancy as well as in the lactation. It may cause some folate deficiency, but therefore we prescribe the folic acid throughout the pregnancy. And during the breastfeeding, it is safe in the breastfeeding, especially when there is full-term baby. But it is better to avoid in premature babies, baby with a high bilirubin and G6PD deficiencies. In one study where 247 IBD patients who had 240 live births, the risks of fetal anomalies in the offspring treated with the sulfasalazine alone and the combination with the sulfasalazine glucocorticoid, where there was no risk of any congenital malformation. So aspirin is another drug which is safe during the pregnancy, but it should be used in the low dose. Higher dose is especially associated with the bleeding risk, therefore it is avoided, in the higher dose is avoided. So in a meta-analysis of 22 studies of aspirin exposed during the pregnancy, the overall risk of congenital anomalies were not statistically significant. Azathioprine is compatible with the pregnancy. It can be used throughout the pregnancy. In a cohort study of 155 patients, reported no statistical difference in fertility, congenital anomalies, infection, and maternal malignancies. It is also safe during the lactation. Although small amount it is excreted, it doesn't cause any harm to the fetus, to the baby. So in this study, 178 patients where the pregnancies were divided into two groups, azathioprine exposed group and another was azathioprine non-exposed group. In the both group, the study suggests azathioprine is safe and lack of teratogenicity in the patient with SLE and pregnancy. Colchicine is another drug that we use in certain rheumatic conditions. It is found safe during the pregnancy and lactation. In meta-analysis of 54 patients in women with familial Mediterranean fever, we continued the colchicine throughout the pregnancy. There was no congenital malformation during the pregnancy, overall pregnancy. So it is also safe during the breastfeeding. So now selectively we can use during the pregnancy. The drugs that are selectively used during the pregnancy, the NSAIDs, they are safe during the pregnancy, but their safety depends on the timing of use during the pregnancy, the dose of the drug, and specific classes of medications. Women who are having difficulty to conceive may avoid the NSAIDs because in some studies it has found that it inhibits the rupture of luteinizing follicles. Before 20th week of gestation, it is safe. It is considered safe, and there is no risk of any teratogenicity. And in several studies, in several meta-analyses and two large population-based studies, there is no significant increase in musculoskeletal and cardiac malformation, and no impact in the fetal survival. But in some studies, it has shown some major congenital abnormalities, but risk was poor. So in a conclusion, NCRD can be judiciously used during the early pregnancy. Risk is low but not entirely absent. So after 20 weeks, we usually don't use the pregnancy, but whenever there is no alternative available, then we can use NSAIDs for up to 30th week. But frequent monitoring of amniotic fluid level is recommended. We should discontinue the NSAID when oligohydramnios develops. And after 30th week, it is contraindicated. There are limited data regarding the NSAID use during the lactation. If there is no alternative available, then we can use the short-acting, some short-acting in the low dose as possible, like ibuprofen and diclofenac. High-dose NSAIDs are contraindicated, like naproxen and etoposide. They are long-acting and they are contraindicated. They are not given usually in the lactation. So glucocorticoid is another commonly used medicine. There are fluorinated glucocorticoid and non-fluorinated glucocorticoid. We usually use non-fluorinated glucocorticoid because it passes in a less amount during the pregnancy through the placenta. But whenever fetal effect is desired, for example, in the patients with the Sjogren syndrome, as shown by the Dr. Srikriti, when the patient develops the heart block, then we use the dexamethasone because it crosses the placenta. Some of the common risks of the steroid use are premature rupture of membrane, IUGR, pregnancy-induced hypertension, gestational diabetes, osteoporosis, infection. And in some studies, it has suggested that in early studies, it was suggested the corticosteroid may cause the orofacial cleft, but later on, the larger observational studies has shown there is no risk of orofacial cleft when used in the low dose throughout the pregnancy. Glucocorticoids are considered safe during the pregnancy, during the lactation, but whenever the dose is more than 20 milligram, then we advise to discard the breast milk for first 4 hours after taking this medicine, because the peak concentration of breast milk is achieved in 2 hours after the ingestion of the drug. So another biological agent, tumor necrosis factor inhibitor like etanercept and adalimumab, they are also safely used during the pregnancy and lactation. In the larger observational studies and some case report, no significant increase in the preterm delivery, miscarriage and congenital anomalies. There was no risk in the infection to the infant. So TNF inhibitors are generally safe during the pregnancy. Because of the larger molecules, the very few amount is passed through the breast milk. So it is safe during the pregnancy, during the lactation, and it is well digested. The medicine is well digested by the fetal gut, and there is no associated with the systemic absorption. So most of the guidelines, they suggest TNF blocker are safe during the breastfeeding. IVIG, one of the important drug that we sometimes use during the severe cases. It can be continued throughout the pregnancy. Peak transfer of placenta usually occurs at the 30 to 32 weeks. It is also compatible during the lactations. Cyclosporin and tacrolimus can be used in a minimal effective dose, but constant monitoring of blood pressure and renal function is required because it is associated with increase in the high blood pressure. There are some conflicting data regarding the placental transfer, but late trimester placental transfer is documented. The risk of teratogenicity is low. There are some reports of premature labor and sperm for gestational age in the infant. So it is also considered safe when other alternatives are not available, but some professional society says it should be used with a caution. So the drugs that are contraindicated during the pregnancies, moderate to high risk causing the fetal harm. Cyclophosphamide, especially when used during the first trimester, it is teratogenic. The teratogenic effect are limb defect, cleft palates, macroganthia, eye anomalies. So it is methotrexate. Another drug is methotrexate. It is contraindicated during the pregnancy and as well as in the lactation. It should be stopped 3 months before the conception. High risk spread of placental transfer is within 6 to 8 weeks. Methotrexate is not recommended during the lactating period. One of the most teratogenic drug, mycophenolate mofetil, it should be stopped 6 weeks before the conception. It may reduce the oral contraceptive efficacy. Manufacturer data has shown that 119 patients who were exposed to the mycophenolate mofetil, the congenital anomalies were recorded 13%. The reported anomalies were cleft lip, cleft palate, defect in the heart, defect in the limbs, kidneys and esophagus. So it is also not recommended during the lactation. Leflunomide, it is contraindicated during the pregnancy. It should be stopped 2 years before the conception. It has very long half-life. It can remain in the serum for 2 years, and it is also contraindicated during the breastfeeding. So the drugs with the limited information, the information are mostly from the case report, registries and animal studies. So should we prescribe these medicines or not? Still there is dilemma. Rituximab, some of the guidelines they have provided, they have given the information. It can be prescribed throughout the pregnancy, like EULAR and ACR guideline. They says it can be accepted during the pregnancies when benefit outweighs the risks. Placental transfer increases in second and third trimester. During the lactation, it is excreted through the breast milk in the small amount. It can be given during the lactation, but frequent monitoring of complete blood count and B cell count because of the immunosuppression to the babies. Rituximab exposure in 153 pregnancies, it was shown 2 congenital anomalies that were club foot and cardiac defect, and both the patients were exposed to mycophenolate mofetil before conception. Small molecular agent like tofacitinib, they are not recommended by any of the guidelines during the pregnancy as well as lactation. So now facts and myths regarding the immunosuppression and basic and biologics during the pregnancy. All immunosuppression are contraindicated during the pregnancy. This is incorrect. Several immunosuppression like azathioprine, hydroxychloroquine and TNF inhibitor are considered safe and can be routinely given. Exposure to biologics always require pregnancy termination. This is incorrect. Many biologics like TNF inhibitor can be continued throughout the pregnancies. Methotrexate and mycophenolate mofetil are safe if taken only in the early pregnancy. This is incorrect. Methotrexate and mycophenolate, they are highly teratogenic. It should be stopped long before the conception. Breastfeeding is unsafe during the immunosuppressive therapy. Many agents like azathioprine, hydroxychloroquine and TNF inhibitor are compatible during the breastfeeding. Women with autoimmune disease should avoid pregnancy. No, it is wrong. With proper planning and disease control, women can continue the pregnancy and have a safe pregnancy. So I want to wrap up with this take-home message. The safe drugs during the pregnancy are hydroxychloroquine, sulfasalazine, azathioprine and colchicine, as well as low-dose aspirin. Should be used with a caution. Cyclosporine and tacrolimus, there is increased risk of hypertension and renal dysfunction. NSAIDs that can be given in the first and second trimester. Low-dose corticosteroid, TNF inhibitor. Contraindicated during the pregnancies. Methotrexate, mycophenolate mofetil, cyclophosphamide and leflunomide. The drugs with the limited data available, rituximab and JAK inhibitors like tofacitinib. Need to terminate if accidental exposure occurs, but decision should be individualized. We have to respect the decision of the patients. So methotrexate exposure, mycophenolate mofetil and cyclophosphamide in the first trimester, it is better to terminate the pregnancy. Thank you for the patient's hearing.
Thank you, doctor. It was very well explained and elaborate and such an important topic that we can get so impressed with this, because we are always worried which drugs we are using, what is going to happen to the children, the babies, the embryos also. So really thankful for this. So any questions?
Yeah, I have a question. Can you please pass the mic?
Good evening, everyone. So I would like to know your take or advice for the male patient with lupus nephritis who are already on mycophenolate mofetil. As you said, they are contraindicated or can't be used, especially in case of female. But what's your take for male patient with lupus nephritis already on MMF and they are planning to extend the family? Should they continue the medications or should they drop the medication and start with the new one?
So I have already mentioned that mycophenolate mofetil, the exposure in the paternal in male patient, the data is very limited regarding the paternal exposure of these medicines, but we usually follow the guidelines similar to that of the female exposure. But in case of mycophenolate mofetil, some of the studies, some of the guidelines from ACR and some European guidelines, it can be continued and can be continued and they can continue for the conceptions. It need not to be held.
end of the session, and then we'll proceed towards the panel discussion.
तिनवटा राखेर दुईवटा दुईवटा छ पाँचवटा भएको तिनवटा र पाँचवटा हो पाँचवटा छ तिनवटा
So after the wonderful two very interesting topics and a kind of slight introduction towards the rheumatic disease and its complication in pregnancy, now we are here. Now we are here for the panel discussion. And for that, first I would like to request the panelists to be on the stage. I would like to request Dr. Swati Shah. She is IVF specialist, consultant obstetric gynecologist, and she is associated with Vardhan Fertility Center, Kathmandu. Ma'am, can you be on the stage, please? Now, here we have another panelist, Dr. Rasmi Shiris. She is expertise in fertility specialist and cosmetic gynecologist, and presently she is affiliated with Maya IVF Clinic. She's chairperson of Angel Fertility Clinic, Maharashtra, and director of Flora Gyne Aesthetic, Lalitpur. Ma'am, can you be on stage and be seated, please? Now, another panelist we have already heard her presentation. Dr. Srikti Sresha, please be on stage. I would like to request Dr. Sudhir Karnacharya to be on the stage. Dr. Adip Arun Shrestha, he is a rheumatologist in National Center of Rheumatic Diseases. Please kindly be seated. today I'm here to present a case which we have today we'll be discussing a case about managing pregnancy in patients with lupus and APS. We have a case scenario which we actually managed the patient, and ultimately we had a very good fetal outcome at the end of the pregnancy. First, the patient outcome. The patient is 34-year-old female. She was from eastern Nepal. We encountered her in our periphery branch, Petamud branch, and she was diagnosed with systemic lupus erythematosus with class 3 lupus nephritis when she first visited our clinic. So we suspected the comorbidity condition of suspected APS since she had 2 pregnancy losses and an equivocal serology, which I will be discussing in detail afterwards. This status when we met her was the family was incomplete and she was planning for the conception. Now, the patient initially presented with classic symptoms of active lupus, intermittent low-grade fever, which was not associated with infection, which was ruled out. This was back in 2019 when she presented in the BPKHS OPD. She had low-grade fever, fatigue, oral ulcers, migratory arthritis, especially the small joints, photosensitivity, malar rashes, which is typical of lupus, and shortness of breath. On examination, her vitals were within acceptable limits, but labs finding confirmed active lupus nephritis. Now here, the investigation which were performed in this everything was not done in our clinic. This was the retrospective data which she had in her file, which was done in BPKHS. The key investigation they performed was in hematological. They performed CBC, which showed pancytopenia, decrease in hemoglobin. Total count were only 1,500. Platelet counts were down, and in the renal function seems acceptable. The 24-hour urine protein was slightly high in the higher side, and the CRP was negative. The doctors there, physicians especially, they went for the ANA and DSDNA test. ANA came to be positive, and DSDNA it was 1:10, which was in that test it's positive, and the direct cum test it was negative. They ruled out tuberculosis, MON2 as negative, and due to the shortness of breath, they performed echo, and there the echo showed hypokinesia, global hypokinesia, and ejection fraction was only 20%. On the USG, there was splenomegaly but no ascites. There they managed with oral glucocorticoid at 1 mg per kg, and hydroxychloroquine was started, and the patient was discharged. Now, over the time, the symptoms of shortness of breath and fatigue improved, but the proteinuria that persisted. 24-hour urine protein was 2.5 gram per 24 hour, which was high, and the physician went for the renal biopsy. Renal biopsy showed focal lupus nephritis class 3. Echo was done after the conservative management. Echo, the ejection fraction was improved to 65%. There was no pericardial effusion. And the diagnosis made at BPKHS was lupus nephritis with lupus myocarditis. And over the time in 2022, patient's disease activity was stabilized with near normal lab reports like CBC being almost normal, stable renal function, but 24-hour urine protein was in low positive range. But there was no RBC or any cast in urine routine examination. On echo, the ejection fraction was 68%, and there was no pulmonary hypertension. The treatment that she received was Visolon, prednisolone, started at 50 mg and tapered accordingly. And hydroxychloroquine 400 once a day was started, and she was kept on Mycofit 500 twice a day. And other supportive medications were there. Now, the recent status which we encountered in our OPD, patient presented with joint pain with 5 months of history, generalized fatigue and body pain. There was no such swelling or effusion as such in joint, but she complained of extreme fatigue and she had relatively arthralgia. And she said that she was having everything normal, but she had this throat pain and common cold, which in documentation was recorded as URTI, and which was resolved with conservative management with antibiotics. The lab reports there was CBC was within normal range. It was not. The counts were not that very high. And patient was maintained on mycophenolate mofetil 1 gram OD, and she was off steroid at that time when he encountered her. But she came to us with a desire for conception. She was saying, I'm having this problem, but I want to conceive. Is it possible or not? Then we went for the past history. We asked her about the obstetric history. She had one pregnancy, which was live birth, 2.8 kg, female, and she complained of there was some kind of BP, rise in BP. अलि blood pressure चाहिँ बढेको थियो doctor, तर खै औषधि त केही पनि दिनु भएन. That was what she said. So antihypertensive, it was not recorded, and then there was no use of antihypertensive postpartum too. And after that, she again conceived, but had miscarriage at 16 weeks. She does not know at 16 weeks. The reason was very unclear. And third pregnancy, it was 8 weeks, and it was early miscarriage. So on examination, we suspected of possible flare because she had oral ulcer. Buccal and palatal ulcers were there. Papular erythematous rashes on the body. And there was now visible arthritis. There was swelling of wrist and ankles. And also on taking history, she complained of Raynaud's. Vitals on while we examined her in our OPD was 120/80 blood pressure, and heart rate was within normal range. On auscultation, chest and heart sounds were almost normal. On investigation, the counts, the CBC, hemoglobin started to drop with normal total count and platelets. CRP, which is the inflammatory marker, it came to be positive, and the creatinine, which was previous in normal range, had slightly increased. It was 1.4, and 24-hour urine protein, it has slightly increased to 157. In urine routine examination, there were pus cells plenty, RBC 6 to 10, protein was plus, hyaline cast was present. So further investigation, we asked her for the further investigation. We performed musculoskeletal ultrasound in the swollen and painful joint. We chose right wrist. It was active synovitis, and there was extensor tendonitis. Inflammatory markers like CRP was increased, the normal range being less than 6, it was 52. Hematology, again the pancytopenic pictures were there. Hemoglobin dropped, total count dropped, and then platelet was also less. And we asked for the APS panel looking at her obstetric history. Here, the cardiolipin antibody IgM and IgG were equivocal, and lupus anticoagulant and beta-2 glycoprotein, they came to be negative, and complement C3, C4 was low. And in ENA panel, we had SSA, SSB, dsDNA, nucleosome, histone, and then the UNRNP. This is the lab reports which we perform in our own lab. The ENA panel, which was not done previously in BBKHS, we asked her to do, and certain antibodies were positive, significant like SSA, and then the dsDNA, it was very in high quantity. And this is the nail fold capillaroscopy. Since she complained of Raynaud's, the capillaroscopy also suggestive of the active phase of disease. Now, the therapeutic challenge, is it the disease flare during preconception? How are we going to manage? How are we going to counsel her for the conception? Now, in this scenario, the renal function was worsening and there was new onset of arthritis. Equivocal APS with 2 losses, do we start anticoagulant or not? On MMF, do we need to switch or not, since MMF is totally contraindicated, as Dr. Sudhir has said previously. So this was the dilemma we had. Now we decided to switch to pregnancy safe medication, but for that disease need to be in the remission. So disease activity was initially controlled by the dose of MMF to 1 gram OD to 1 gram BD with prednisolone tapering dose. Then after obtaining remission, MMF was stopped and switched to azathioprine. Hydroxychloroquine was continued. Prednisolone was with tapering dose, and we started low dose aspirin with 75 mg, and strictly monitoring of dsDNA, C3, C4, CBC, KFT, and urine total protein was done. Now, the patient was in stable, or as we say, in the remission phase, and 5 months later, after the medication switching to azathioprine, and when she was serologically in remission, we repeated the labs. So CBC was within normal range, CRP decreased to normal, dsDNA was negative, and 24 urine protein was 50 mg for 24 hours, which was negative. And APS panel, when we asked for the APS panel, the antibodies which previous was equivalent came to be negative, or the antibody was not detected. Now,
Ask question to the panelists at this point.
Okay, then for the question, first I would like to go back, and during that therapeutic challenge, I would like to ask Dr. Sudhir Karmacharya here. Here I would like to ask him what would be the timing of conception in lupus patient, how long should remission be maintained, what are the what are the protocols, or what are the guidelines says. Can you explain a little bit on that?
Thank you for the question. Actually, in the lupus patient, already the Sukriti has also mentioned, the patient should go under remission for at least 6 months. 6 months, he should not have any clinical feature of lupus. All the disease activity should be low. SLE score should be as minimum as possible. So whenever the patient is for the remission for 6 months, then we can proceed for the conception and pregnancy. For this particular patient who is having the renal flare, and patient is having lupus nephritis, and when you encounter the patient after the second time after they had already treated in BPKS, she had again renal flare. So you gave the induction with the mycophenolate mofetil 2 gram. Then she went remission in 5 to 6 months. I think that was the safe rate, and you converted then the patient to the azathioprine, the safest medicine. So in my answer is yes, we can continue the pregnancy, but patient should be in a remission for 6 months.
But here she presented at 5 months. So can we consider that, or is it a hard and fixed rule that it should be 6 months?
It should be 6 months, minimum 6 months, according to the guideline. If we consider the ACR and Euler guideline, then patients should be in remission for minimum 6 months. But if the patient is in a renal flare, then the guideline says 6 months to 1 year. The patient should be in the renal remission, should not have any proteinuria, renal hypertension, near normal creatinine or near normal creatinine.
Now,
another question regarding the dilemma of changing MMF to the pregnancy safe medication. I would like to ask Dr. Odin Shrestha about like timing and consideration when to switch the medication.
Thank you for the question. Regarding this case scenario, here patient had already told that patient wants to conceive. So once the patient was on remission, patient was shifted to azathioprine, a safe medication which we can continue throughout the pregnancy. However, ideally, mycophenolate mofetil, which is contraindicated, as we have already heard in our last presentation given by Dr. Sudhir, mycophenolate mofetil is contraindicated and it has several birth defects like cleft lip, cleft palate, renal and cardiac anomalies. Also, risks of miscarriage are there. So we actually need to stop mycophenolate mofetil at least 6 weeks prior to pregnancy and switch it to azathioprine, which is safer, and the dose should be less than 2 mg per kg per body weight. However, in this particular patient, the patient initially presented with pancytopenia picture, which was done in BPKHS, and maybe that is disease flared that time. However, azathioprine is also a myelosuppressive, which can cause pancytopenia. So we also need to do TPMT test before starting azathioprine. Thank you.
Thank you very much. Now, another dilemma here. There's equivocal APS. What to do with that? Do we treat equivocal APS as definitive? Dr. Srikiti, can you have some?
Thank you for the question. Equivocal APS, we will define it as if there are clinical features that are associated with APS, but it is not of diagnostic criteria. And if there is presence of antiphospholipid antibody, but there is only single antibody present in low titer and in only one occasion. The answer is no. We do not treat equivocal APS as definite APS. But what we do is we go for close monitoring of the patient to look for if they will develop certain symptoms that are in diagnostic criteria. We will repeat the test after 12 weeks, and we will assess the risk factor associated with the condition, traditional risk factor that includes smoking, diabetes, hypertension, any cardiovascular risk factor associated. We will assess that. If there is only one antibody present with no prior history of obstetric morbidity or any thrombosis event, we do not treat it. If there is previous obstetric morbidity, then low-dose aspirin can be recommended. Having said that, in this particular case, in the background of SLE, there is a pregnancy loss history of one fetus at 16 weeks that can be calculated as one diagnostic criteria. So in this particular scenario, we can go for low-dose aspirin as well as low molecular weight heparin, which we can continue till 6 weeks after post-delivery also.
Dr. Dina also has a question, and at this point, I think we should agree to disagree sometimes. Yes, in the background of lupus, as Dr. Srikiti said at the end, with history of pregnancy loss and equivocal, and specifically if that is lupus anticoagulant, that's anticoagulant. If it is lupus anticoagulant positive, that is the notorious one for recurrent miscarriages. Anticardiolipid beta-2-glycoprotein are more risky in cases of DVT and early onset thrombosis, arterial and venous. But if it is lupus anticoagulant, even in equivocal positive with history of significant pregnancy loss, that's anticoagulant. Dr. Dina.
I'm really sorry. I think I'll never see these patients, but I really am curious what happened. So that renal function worsening, there was pulses plenty, right? And then like the protein urea was high and the creatinine was 1.4. So did you treat the UTI or you just say that it's part of this system. That was my number one question, because that's what we struggle with diabetic people. And the other thing was, how did that 20% become 60 and then 68? Like global hypokinesia, like is that normal for you guys to like, does rheumatic disease affect the heart and then you treat them and then it becomes 68%? Like I would want my patients to be that gloriously well, so that's the only reason why I literally took the mic.
Okay, then I'll take the questions.
Okay.
Okay, so the pustules that we see in urine routine examination is most likely they are active sediments. And active sediments are neutrophilic residues, and in routine urine microscopy it comes as pustules. But if the pustules are present with RBCs, slight amount of RBCs and proteinuria, we suspect active sediments. There are few nephrologists who, pathologists who see active sediments in the urine. So if you have that facility, ask them to see for active sediments. But in the scenario of low complement levels and high DHDNA, and then there are other parameters like high inflammatory markers, rising creatinine, less likely it's UTI. So that's how we decide for flaring.
You don't treat.
No, we send for urine culture, obviously if there is organism, and then we treat, but it's usually lupus flare. The second question was improvement of global hypokinesia, and that's usually in lupus patients it's lupus myocarditis. In flare there is myocarditis that causes global hypokinesis, which is reversible. Similarly, like postpartum cardiomyopathy, which is only cardiomyopathy that is reversible, right? So similarly in lupus myocarditis, even if it's global hypokinesia, give steroids and it can be reversible.
So here I would like to proceed with my case. So we switched to pregnancy-safe medication. As we have discussed, the MMF was stopped, azathioprine was started, hydroxychloroquine was continued, low-dose aspirin was started. So I think I did correct here by starting low-dose aspirin here. Now, here, 5 months later, a patient was clinically and serologically in remission, GSDNA negative, APS panel negative. And then here, I would like to pause and I would like to ask some question to our panelist gynecologist, Dr. Swati Shah. What is the role of hormonal therapy like estrogen, progesterone in SLE patient trying to conceive? We as a rheumatologist, we do not recommend any hormonal therapy. What about the take in gynecology setting?
As we know, estrogen, it has immunomodulatory effect. It has pro-inflammatory effect. So, high level of estrogen, it increases the risk of thrombosis as well as flare in SLE patients. So, in such cases, if the patient wants to conceive, we should go with low doses of estrogen. And if we are going with IVF, we should go with mild stimulation protocols, which includes low doses of FSH, that is 150 international units. Along with that, we can use letrozole, which is aromatase inhibitors. It also decreases the levels of estrogen. And on the other hand, we have to also consider the risk of OHSS in such cases, as it has a high risk of thrombosis in OHSS cases. So we should go with GnRH agonist trigger in such cases, and we can consider the use of low molecular weight heparin or aspirin if there is history of previous thrombosis or APS is positive. And once we go for we should not go for fresh transfer in such cases, because with fresh transfer there is high chances of flare again and risk of thrombosis, and OHSS again, which increases the risk of thrombosis in SLE patients. So we should go with frozen embryo transfers. And in frozen embryo transfer also, the protocols for frozen embryo transfer, it includes natural cycle or modified natural cycle embryo transfer protocols, in which we usually go with tamoxifen or use of letrozole. And with the use of during the luteal phase support, we can use progesterone, micronized or oral progesterone, dydrogesterone. It decreases, it has anti-inflammatory effect, and thus it decreases the chances of thrombosis in SLE patients and flare in SLE patients.
So this is in the
normal SLE patient who are trying to conceive, not in the IVF case, right? Thank you very much. Now, the patient, after 5 months, came with the history of amenorrhea. We performed urinary pregnancy test and it came to be positive. Here, now we need our gynec support. So I would like to ask Dr. Rashmi Shiris, what are the baseline antenatal tests which are required in lupus pregnancy?
Hello. Hi. Thank you so much for your question. As you already mentioned that she had undergone all the basic investigation like CBC and then CRP, double DNA and urine protein, and here seems okay. And then APS panel is also normal. So I think she can go for natural pregnancy, and already you told me that she had pregnancy positive. Then actually we have to do a multidisciplinary treatment with this particular patient. So we gynecologist will just collaborate with rheumatologist to continue the pregnancy. So for basic investigation is already done. So with collaboration with rheumatologist, what next to be done? Maybe 3 months we'll repeat all the investigation, basic investigation, and we just continue her pregnancy with low dose equilibrium, and then you already told us she is in hydrochloroquine, and then also if she got pregnancy, that she had pregnancy, then we just give her other medication like folic acid, DHA, or vitamin D, or vitamin E, other supportive medication. So we will just repeat her all basic investigation after 3 months. If this is the scenario with this particular patient.
So for the first trimester test, do we do same as a normal pregnancy, or is there any specific other test or any other guidelines related with special pregnancies like lupus pregnancies?
Yes, of course. If we do, if patient come without doing this investigation, then we'll definitely do a specific investigation like we do anticoagulant status, we do ABGT, BG, and then we do like APS panel, we do all investigation like anti-TS DNA, anti-cardolipin DNA, and then we also see C3, C4 level also. And then also we do basic ultrasound and ECG echo of patient itself, for, like other patient who not this particular patient.
Normal pregnancy.
Yes, normal pregnancy. If they come with SLE, history of SLE, we do all the investigation.
Thank you very much. Here, I have another question here. Here, APS panel is negative, but what if it confirms to be the triple positive or equivocal or single positive antibody? Would you like to give some enlightenment in this topic, Dr. Srikiti Shrestha?
Triple positivity is definite APS, so we should definitely treat that. Depends on primary prophylaxis and secondary prophylaxis. For primary prophylaxis, if there is high antibody positive, but there is asymptomatic carrier, then we will recommend low dose aspirin only. In SLE patient, in general SLE patient, if there is with no prior history of obstetric morbidity and thrombosis, if there is high positivity, we'll go for low dose aspirin is recommended. But if there is low positivity, low dose aspirin is considered. Similarly, in secondary prophylaxis, if there is high positivity in normal population with first venous thrombosis, then we will prefer vitamin K antagonist with target INR of 2 to 3. If there is unprovoked thrombosis, then anticoagulation should be continued for the long term. If there is provoked thrombosis, then we can go as for normal population, but there are data of recurrent thrombosis where we have only continued anticoagulation for just 3 to 6 months, so long-term anticoagulation is better. In obstetric population, if there is high positivity antiphospholipid antibody, but without any obstetric morbidity and thrombosis, we will recommend low-dose aspirin in obstetric population with one fetal death after 10 weeks of gestation or 3 consecutive loss before 10 weeks of gestation, and there is delivery before 34 weeks of gestation due to eclampsia, pre-eclampsia. Then we prefer low-dose aspirin plus prophylactic dose of low molecular weight heparin, which is generally continued till 6 weeks of pregnancy.
Thank you very much. I would like to proceed with the case. Now, first trimester, she presented at 7 weeks of gestation, amenorrhea, urine pregnancy test seems to be positive, and we confirmed the viable uterine gestation by TDS, and low molecular weight heparin was started. Azathioprine, hydroxychloroquine, ecosprin was continued, and routine labs, like Dr. Siri said, we asked her to do that. Now here, giving a pause, I would like to ask Dr. Swati Shah, before I ask about the pre-conception hormonal therapy, what about should hormonal therapy like progesterone supplements be considered in early pregnancy for SLE or APS patients?
In SLE and APS patient, as this patient, she had history of one early miscarriage plus fetal loss at 16 weeks. So we can consider use of progesterone in early pregnancy till 20 weeks of gestation, as it supports pregnancy and also it prevents flare in SLE patients.
And now moving to the second trimester, there was mild rise in proteinuria during the routine examination. Previously it was 50, and now it was 280, and complements were remained low. There was no clinical signs of flare, but closer follow-up was planned. Medications were continued with no increase in dose of steroids. Now in third trimester, there was onset of hypertension. At 32 weeks of gestation, blood pressure was 140/100, but there was no headache, no visual symptoms, and labetalol was started. Now here again, I don't know, when should we screen for any anomaly or malformation scan in lupus patient? Is it similar with the normal pregnancy, or is it we need to make it more frequent? Can you answer this question, Dr. Swan, please?
So anomaly scan in cases of lupus patients, usually it is started at 16 weeks and it is repeated every 2 to 3 weeks till 24 weeks for sake of anomaly, and as well as fetal echo is also started at around 16 weeks and it is repeated every 2 to 3 weeks, every 2 to 3 weeks till 30 weeks. So rule of congenital heart block.
So is it similar with the normal pregnancy, or we do it more frequent?
No, in normal pregnancy, usually we do one-time anomaly scan. It is done usually at 18 to 22 weeks of gestation, and fetal echo, it is done at 20 to 22 weeks. Once a month.
Now at 34 weeks of gestation, there was mildly elevated CRP, dsDNA titer started to increase, platelets were normal, CT-C4 further decreased, and at 36 weeks of gestation, there was mild IUGR noted in growth scan. Blood pressure was 150/120, proteinuria further rose to 320, and the LFT, PTINR were normal. In urine routine, protein plus, no active sediment, no signs of hemolysis or thrombocytopenia was noted. Now here, there was dilemma. Is it lupus flare or preeclampsia, eclampsia? So how do we differentiate that? Dr. Sudhir, can you answer this?
So if we see this picture, then definitely there is a flare of lupus. because there is rise in dsDNA, CRP is raised, platelet maybe normal in lupus, C3, C4 are decreased. But if you see this scenario, this is really confusing because blood pressure may be raised in both the cases. Proteinuria may increase in both the cases, and there is no active sediments over there. The active sediments we expect in the lupus flare, proteinuria is present over there. So differentiating lupus flare and pregnancy is really challenging. But there are certain factors how we can differentiate it. As in the previous slide, in Swikriti's presentation, she had clearly mentioned the slide. The preeclampsia usually occur after 20th week of gestation, but the lupus flare can occur anywhere in the period of the pregnancy. The other clinical features, we can also differentiate it by the clinical feature. If the patient has a clinical features suggestive of the lupus, like joint pain and increase in the oral ulcer, alopecia and other features, then we go for the lupus flare. And in the lab markers are already mentioned here. So it is difficult to diagnose whether the patient has lupus flare or preeclampsia. Definitely we need a multidisciplinary approach with gynecologists too.
So we concluded this as lupus flare, as there was rising dsDNA, falling C3, C4, rising CRP, and stable platelets and LFT. Now here, Dr. Adib, can you say anything about the steroid dosing in this stage? Do we need it? How do we adjust that?
Actually, we need to come from the beginning of the pregnancy here. So patient was already in immunosuppressive azathioprine, hydroxychloroquine, and as I have seen there, it was patient was already in low dose steroid. So in this patient, if steroid is safe or not. So low dose steroid is considered safe throughout the pregnancy. We can give low dose steroid in mild disease activity. However, in this case scenario, when it's 34 weeks with disease flare, when we considered it's lupus flare diagnosed based on dsDNA marker, low complement level, rising CRP, and stable platelets and LFT, it's not a preeclampsia, it's lupus flare. We can see the disease activity of the patient by SLEDAI score. If it's less than SLEDAI score is 3 or less, it's mild disease activity. If the SLEDAI score is 3 to 12, it's moderate disease activity, and if it's more than 12, it's high disease activity. So considering steroid, in mild disease activity, we can go to low dose steroids like 5 to 10 milligram per body weight, 5 to 10 milligram once daily. However, if it's moderate disease activity, moderate to severe disease activity, we can go up to 0.5 milligram to 1 milligram of 1 milligram per kg per body weight of prednisolone. However, if it's lupus nephritis flare, we can also go to methylprednisolone pulse therapy here for 3 days.
Thank you. Now here, Dr. Adib has said we can use a low dose steroid according to the disease activity, and we can even go for the methylprednisolone pulse dose. How do we manage here? What do we need to go for any higher immunosuppressant, or do we go for methylprednisolone pulse? How do we manage here during the pregnancy and flare of lupus? Dr. Swikriti, can you answer this question, please?
Flare should definitely be differentiated from physiological changes of pregnancy. Like Dr. Sudhir said, there is confusion. So it should first be confirmed it is flare or it is just preeclampsia. After confirmation, we have to look, is it mild, moderate or severe flare. In mild flare, as said by Dr. Adib, we can just increase the dose of steroid, low dose 5 to 10 mg. If there is moderate to severe flare, then we need to add methylprednisolone for at least 3 days, and we can skeletal immunosuppression as well. In this case, there was hydroxychloroquine, but if there was no hydroxychloroquine, we need to add that. We need to increase the dose of azathioprine. If it is not it is not sufficient, then we may add calcineurin inhibitor. In some cases, if the fetus is viable, we need to terminate the pregnancy also after 34 weeks of gestation. As mentioned by Dr. Sudhir, we generally avoid cyclophosphamide in first trimester, but in organ-threatening condition, we have to use cyclophosphamide considering if there is severe flare, and if it is organ-threatening, we can switch to that also.
So here, Dr. Sudhir has said, if the fetal is viable and after 34 weeks, we can consider termination of pregnancy. Dr. Rashmi, can you answer this question regarding the consideration of termination of pregnancy or continue? What is the threshold for planning early delivery?
Actually, in this particular case, it's already seen that in 34 weeks, she had a flare of lupus, and then 36 week is continuing as a preeclampsia, either flare of lupus or preeclampsia. At 36 week, we consider if viable pregnancy, if even fetus is doing okay, we'll consider termination pregnancy. Means we do a analysis, we have to deliver a baby. As soon as we deliver a baby, either preeclampsia, lupus flare will get down, and then viable, not viable is different path, but it is a particular patient is already seen flare up, and then already seen BP is going high, and flare up is there even with all other medications, so we have to terminate the pregnancy. We will not continue pregnancy. Even after 32 weeks, if she come with flare up, and then with preeclampsia features, with proteinuria, and then high BP, even with the antihypertensive, then we have to terminate pregnancy even at 32 weeks with consideration of like dexamethasone to have like long maturity, and we not recommended to start corticosteroid or other cyclophosphamide or other things in this particular pregnancy. If if she's planning, then only we consider other medications. Thank you.
So here if the pregnancy was 32 weeks and presented with this symptom, we can terminate the pregnancy. What if before that? Can we terminate, or can
Yes. If the patient is developing severe like hypertension and proteinuria or renal nephritis or like myocarditis or pleuritis, any organ involvement with lupus, and also fetal problem like oligoamenorrhea or very severe low birth weight, or still IFT, then we have to terminate even before 24 weeks or 30 weeks.
Thank you, Dr. Sulis. Here, I would like to be more clear, and I want senior rheumatologist opinion too. Dr. Vinit, can you give your idea? Patient went to gynecologist at 32 weeks of gestation. Not this case. 32 weeks of gestation, as Dr. Siris has said, there is signs of preeclampsia, there is flare, and she wants to terminate the pregnancy. But it's a precious pregnancy, and she comes to you and she says, gynecologist has asked me to terminate the pregnancy, but what about, can I continue or not? What about the rheumatologist point of view?
So if it's not a life-threatening situation, I think termination would be better. Elective or emergency CS, because 32 weeks the fetus is quite mature. Maybe you would like.
Delivery of baby, yes. Not termination.
No.
Not operation, but it's a delivery of baby.
The fetus is already mature, and we would like to give few sources of
We can
dexamethasone.
safely deliver the baby with all this life-threatening complications.
And most of the time, what we have seen is that the flare usually goes into control with steroids only. But if the patient does not go into remission, then obviously we'd like to induce with cyclophosphamide or rituximab. But then there are cases when the fetal maturity is not very sure, it's a precious pregnancy like 24, 28 weeks, we cannot save the baby even with like long maturing agents. In those cases, I would recommend rituximab if the patient is affording, and if not affording, still cyclophosphamide can be given even after the second trimester. So if it's a precious pregnancy and the baby is immature, we go for induction with cyclo or rituximab. Rituximab preferable, but yes, if the fetal maturity is established, then definitely we go for delivery.
Thank you, Dr. Mendes. Now, after all these discussions, the management of flare of pregnancy was done. Prednisolone dose was increased, as Dr. Adib has said. Azathioprine was continued. There was no need of use of any higher immunosuppressant. Low molecular heparin was paused and switched to unfractionated heparin infusion before delivery. Fetal monitoring and corticosteroid for fetal lung maturity was given. Here, Dr. Sudhir, can we ever stop low molecular weight heparin midway between pregnancy if antibodies disappear or become negative?
So when we decide to give the low molecular weight heparin and when previously the antibody were positive, it is unlikely to become negative. It may be transiently negative, but later in the pregnancy, the patient may again develop the positive antibody. So no, we cannot terminate the low molecular weight heparin.
So whatever the lab reports, we go with the use of low molecular weight heparin.
And in lupus patient, if we even don't have positive antibodies, but there is frequently loss of the pregnancy in the previous history, then we go for the low molecular weight heparin. It is better to go with low molecular.
Continue throughout the pregnancy. Then when should we consider to change low molecular weight heparin to unfractionated heparin? When can we switch that? Dr. Sripiti, can you answer this?
Low molecular weight heparin has long half-life, so about 10 to 12 hours, whereas unfractionated heparin is reversible with protamine sulfate. So we can switch to unfractionated heparin after 36 weeks of gestation. We can stop it just 4 to 6 hours before delivery of the baby. That is for pregnancy. In another case where we can switch low molecular weight heparin is if there is renal impairment. If creatine clearance is less than 30, then as low molecular weight heparin has renal clearance, so it will have some effects. So unfractionated heparin is safe in those conditions. As well as in catastrophic APS, we can go for unfractionated heparin. And if there is high bleeding risk, then also we can go for unfractionated heparin because we can reverse it with protamine sulfate anytime we need.
Thank you. Now, so we planned for the delivery. Mode of delivery was elective C-section at 32 weeks due to the maternal risk. Heparin was held 12 hours prior to surgery. She delivered a healthy male baby weighing 2.6 kg with Apgar 8/10. Now, postpartum, the disease remained clinically quiescent, and we continued azathioprine and hydroxychloroquine. Low-dose steroid was used, and here low molecular weight heparin prophylaxis was given. But I would like to ask Dr. Adib, how long should anticoagulant, low molecular weight heparin or aspirin be continued after delivery in APS?
Actually, here we have already written that low molecular weight heparin prophylaxis for 6 weeks postpartum. So we will be continuing low molecular weight heparin or either antiplatelets, ecoaspirin for 6 weeks postpartum because it's the all postpartum period is a hypercoagular state. So if the patient is already an antiphospholipid patient with lupus nephritis, they have a compounded risk of thrombosis. So we will continue low molecular weight heparin for 6 weeks postpartum time.
then should we start? When should we restart the anticoagulation postpartum? Like immediately, or is there?
Actually, we can start anticoagulation immediately after the delivery. However, in this patient, we have done cesarean section, so it's better to start after 12 hours from the cesarean section. However, some guidelines have said that we can start it after 36 hours as well.
Thank you very much. Dr. Vineet, would you like to summarize this panel discussion? What about your takeaway message?
I think this was a fruitful discussion, and all our friends, because this kind of case scenario is a day-to-day scenario. We get referrals, and it's difficult to manage cases, and obviously both to you and to us. And this was the reason we decided to have this meet in person to clear the confusion regarding the drugs and the management. So I think this case almost is a representative case of all possible complications that we can encounter in a patient with rheumatic diseases, and most of the guidelines are clear. If there is flare in early pregnancy, low-dose NSAIDs and even low-dose steroids are safe. In late pregnancy, do not give NSAIDs, give steroids. In steroids, do not give fluorinated ones which crosses the placenta unless you want it to cross the placenta, like for fetal maturity. You want it to cross the placenta, give dexamethasone which is fluorinated. Deflazacort is fluorinated, so no deflazacort in pregnancy. Prednisolone is safest drug, beta-hydroxy steroid dehydrogenase enzyme that inactivates the prednisolone in placenta, so low to moderate doses is considered safe. So, and those are the straightforward things. Confusion always arises in anticoagulation, so whether we need to anticoagulate, and I agree with Dr. Sudhir that in cases with lupus and recurrent pregnancy loss, with or without history of thrombosis, it's better to anticoagulate with low molecular activity. 2 or more losses, even I say if it's one significant loss in second trimester. First trimester, 2 or more losses, we need to anticoagulate, because see, if you understand the pathology of antiphospholipid syndrome, those are antibodies against phospholipids, as the name says, and we are testing only 2 anti-phospholipids, anticardiolipin, and now we are testing beta-2 glycoprotein. Previously, we used to test only anticardiolipin and lupus anticoagulant. So lupus anticoagulant is not an antibody-based test. It's just a test to mix patient serum with some piper venom and see if there is anticoagulant activity. So that is why it is significant. So it's not based on antis and antibody reaction. So beta-2 glycoprotein is detected only if it's there. Lupus anticoagulant, cardiolipin is detected only if it's there. What if there is antiphosphatidylserine inositol antibody, phosphatidylserine antibodies? These are also antiphospholipid antibodies, and there's no test to detect them. So doesn't mean that if those antibodies are absent, patient does not have APS. So if there's recurrent pregnancy loss, especially in patient with lupus, less anticoagulant. I think that should be the bottom line. And regarding this case, I do not think there are any other confusion, but if there's any questions on the floor, then we'd be happy to answer.
Yes, any question? If no, then I think we should close the session because it's getting late and I think everyone is hungry. So we further go for the felicitation program. Yes, we further go for the felicitation program, and I hope everyone coming here has some takeaway message regarding the this rheumatic disease and pregnancy. केही नभए पनि I think अब त अलिअलि त क्लियर होला हामी. Like Diana, and we need to go hand by hand, side by side, and yes, both we want betterment for the patient and the special pregnancies and the precious pregnancy. We rheumatologists and we gynecologists, we definitely like to see that. So, Dr. Vineet, for the felicitation program.
And in the meantime, we would really appreciate your feedback because this is the first of its kind type of meeting we have thought of, and we'd like to know if it has been fruitful and if it can be made more more fruitful in some kind of way. If you have received an invitation message on WhatsApp, you can reply on that on your feedback. If you have not, then we'll send you one so that we can get your feedback and plan the future programs accordingly. And also let us know if we should have a kind of a platform to connect with where you can. It's not always easy to send the patient. So if you have any confusions, like you can send a case summary and we can have a feedback on an online platform or WhatsApp number. If you think that's going to be helpful, then maybe we can create that one just for this obstetric chapter. Thank you.
Good evening, and once again welcome you all, distinguished guests and all participations, because participants is very important. And thank you so much our speaker, Dr. Sukirti Srishta, Dr. Sudeep, Dr. Manisha, thank you, and our moderator, wonderful moderator, Dr. Vinay. Thank you so much that you have associated with Lupin. It's really nice. And I want to thank you to our chairperson, Dr. Deena Srishta. A clap for everyone. Dr. Deena Basne and Dr. Tumla Lakol is here. So thank you so much. And our panelist, Dr. Swati Saha, thank you. And Dr. Rashmi Sris and Dr. Adiyek Arun Srishta, thank you so much. And guest of honor, thank you, Dr. Lochan Karki, thank you so much. Dr. Nikita, thank you. And Dr. Bharti, thank you so much. So, we want to call our speakers here to reward them from Lupin. Yeah, Dr. Sukirti Srishta.
जग लाइट है
Dr. Manisha.
कोई मान्छे
Dr. Sudeep. And our moderator, Dr. Vinit Pandey. And our chairperson, Dr. Deena Srishta, Dr. Beena Basne, Dr. Tumla Lakol.
मौसम व्यक्तिलाई भेट्न पर्ने आउनु यतै हुनुहुन्छ नि
panelists, Dr. Swati Saha, Dr. Rashmi, and Dr. Aditya. Guest of honor is there, Dr. Lochan Karki. Dr. Nikita Takal and Dr. Akhil. ये भाड़े बात रहा है Dr. Tumla Lakol, I think she is here. Dr. Akirti. Outside.